The American Chronic Pain Association, Penny Cowan, has put a number of different resources, but not only downloadable things that you can print off and use in your office, like self-monitoring tools or logs or things like that, but she's also got this wonderful opportunity regarding groups and communities. So she's built out a network where patients have formed their own support groups, and there are chances for patients to become facilitators of pain groups. So building on their own strengths. And there's a formal training that they can obtain for free to be a group facilitator and then start one so we have a broader network. And we refer a lot of our patients after they've gone through our formal pain program to go on and do that. So, just as a reminder, this is the list of the basic tenets of pain science education. And this, the top one, the tissue issues, is what I focus most on at first. Just trying to get someone to understand that the amount of pain you're in doesn't necessarily reflect on the health of your body. So let's take the distress down wherever we can and move on. So this definition by Lorimer Moseley again, and this was published back in 2003, the same year that the Explain Pain book was published, to consider pain as a multi-system output of the brain that is produced whenever the brain concludes that body tissue is in danger and that action is required. And so this kind of definition I actually say in different ways with my patients in education sessions to get this notion that pain is about threat, pain is about danger. And that can be actual or perceived danger. And perceived danger is just as real danger or actual danger. You know, there's no difference to me. I think our language makes it seem like one is more important than the other. And it's not true. So, not everything is considered a threat. You know, some people can get bitten by dogs early in life and be dog owners and dog lovers, and other people will never touch a dog and never go near a dog. And nobody's figured out exactly why that might be, but our brains encode information and make associations in various ways. And I think the pain science kind of supports that this manifests itself in terms of pain and how people experience pain. So, tissue problems versus pain problems. I will show pictures like this. I'll talk about examples in life, and with the soldier population, this is easy for people to come up with examples of high amounts of tissue damage and low amounts of pain. And so this quote I use actually a lot at the end of an education session, that pain is not about how much damage you might have. It's not a meter of damage. Todd Hargrove is a colleague I met through my social media network. He's a former lawyer who developed chronic pain and then transitioned in his own seek for care and feeling better. He ended up being a certified Rolfer and a Feldenkrais practitioner. So now he writes about pain science, and he has wonderful things to say in a very nice package, easy to understand, well argued, as all lawyers ought to be. But this quote I use a lot: pain is a call to action, it's not a damage meter. Karen mentioned this. Sometimes all our patients are doing is showing up. And I say to them often, thank you for coming. I'm glad you're here. Your nervous system did its job, right? So tools that I use, I have a whiteboard in my office. It's not paper, it's just a dry erase board. And with patients I feel are ready for this kind of education, remember, I don't use this with everybody at first. Most of the people I see, I end up using this type of education with all of them. But when I said earlier that this type of education is not necessary for everyone, I'm mostly talking about the upstreamers, the people earlier in the medical system who have maybe had one or two traumatic events in terms of body injury or damage, but they recovered and got over it. Now this is their third one, and it's just lasted a little longer than others. They may not need to go down this road. That's okay. But for those who do, this is what I do. I write a little scribbly thing, and I say, this is our brain. And then I draw a little line thing, and I say, see, that's a spinal cord. And I say, that's exactly how they look inside, too, by the way. And we've got a body attached there, and this body, ANS here, stands for Autonomic Nervous System. We've got a lot of different bits of information coming from the body all the time, 24/7. You can't shut it off. And our brain doesn't tell us about most of it, thank goodness. I don't want to know about everything going on inside there. There are a lot of self-regulation systems that kick in when they need to, and when we need more attention, usually the higher level processes will get our attention. That's what thirst is about. Then we've got all these environmental cues that are being filtered through our sensory network. So things that we hear and taste and touch and smell, that all will directly affect our physiology. There are interesting studies about how sweat produced in different situations. One sweat collection produced when people are jumping out of an airplane and they choose to do that and they find it fun, versus sweat from a panel interview when you don't know you even want this job. And when those different samples of sweat, that aroma, the pheromones, are presented to naive people, their bodies respond differently. So all of our senses are cueing our brains to manage a situation and decide on an output. And so I say, how do nerves communicate with each other? Well, there are all these chemicals, special kinds of chemicals, and they convert to electric impulses, and those electric impulses travel up and down. We've got 400 individual nerves, and they're all connected like highways, and information goes in both ways, but remember, it's chemical and electrical. And when all that data gets to the brain, and remember, this happens in a split second. This is so fast you don't even know what's happening. But our brain has to ask this question: how dangerous is this? When it comes to the pain alarm system, our brain is asking, how dangerous is this? And it doesn't ever only sample from the environment or from the body. It's got to scrutinize the meaning of that input based on a lot of things, based on your past experience. So every past experience of pain will influence a current experience of pain and a future one. And that's on purpose, right? If you put your foot in a fire and you get damaged, you better hope you don't keep putting your foot in the fire. There's learning involved. A lot of it is implicit and we don't even recognize it's happening. Beliefs are a big one, and I spend some time on the beliefs bit. And I think that's important because this term, at least in our society, in our culture, belief is not always a positive spin. A belief is something that people don't have to take seriously, right? You believe that, that's fine, but that's not reality. And I think we need to be sensitive to that, because when it comes to challenging beliefs, and I've done it with some of you here today, and I'm glad, and I've had to do it for myself, I do it all the time. When it comes to challenging beliefs, adult learners in general, we all have something called cognitive dissonance, and the mental health specialists probably know what that means. Other people likely will too. That means our brains generally have a hard time computing new information that doesn't jive with our experience. It's just how we're programmed. But challenging beliefs is really important. So what I use often, my go-to right now, is I say, see, I believe that we shouldn't eat bugs. I know they're healthy, and I know that some cultures do that, but I believe that it's just not good for me. And so I know when I'm presented with bugs and someone says I should eat them because they have all these health benefits, protein and whatnot, my nervous system says absolutely not, and I feel it. Do not put that in your mouth. But if somebody toasted up those crickets and crushed them up and put them in some brownies and added some pecans, I would eat those just fine if you didn't tell me there were crickets in them. And my body wouldn't try to rebel against that either. So we can change the way our nervous system behaves based on our beliefs, and we can change our beliefs. Sometimes it takes a while. Context matters a lot, and here's where I might ask, and depending on the person in front of me, I might say, have you ever experienced this where you know how you go to the car, the mechanic, and your car's making funny noises, and then the day you go to the mechanic, it stops making those noises? Right, yeah, I get it, yeah, I know what that's like. Has that ever happened with your body? Like you go to the doctor and it's not doing the thing, and you're not hurting? Or have you ever had the opposite, where you hurt a lot more than you normally do at 2 o'clock in the afternoon? Well, what's that about? Well, think about where you were. Remember that our brains are always scanning the environment for potential threats. That's biology, how we're programmed deep back in there. So context matters, and that'll change pain. And I want you to start thinking about what your different contexts are and how your pain might be different in each one. And the meaning of that pain when you're experiencing it. The meaning might be different if you're someone who works with your back and your back is the thing that hurts. That might mean something different than someone who sits all day and they don't use their back. Everyone's different. So I sometimes, depending on the person, I may pull out some of these different categories and spend more time on them to get a hook, to try to figure out what might help their brain convert a little over to thinking differently. But after I talk about some of these different things that modulate pain, I say, remember, your brain is scrutinizing all of this in a split second, and it's got to decide on whether or not to take action. And sometimes it will and sometimes it won't, and we can't always predict that. And this is all subconscious. It's not like you have control over a lot of this. Okay, I'm not suggesting that. But good news is we can change beliefs if we actively work on it. We can change what we consider to be threatening if we work on it. We can expose our nervous system to things slowly and over time and change the response. But if your body or if your brain decides to take action, a couple things might happen, several things, right? Behaviors will change and physiology will change. Behavior change, we all recognize this. You might move differently. You might protect a limb. Now that's very protective, right? If you hurt your elbow or bang it into a tree while you're running from the tiger, once the tiger is for sure not chasing you anymore, you might start holding your arm like this. That signals to other humans that you might need some help. That's natural. So pain behaviors are part of the deal, right? And they're not always conscious. You might start limiting your activities. You might ignore the pain and do more activities just to keep yourself distracted. All of these are behaviors that go along with the changes that your brain is dictating. And the physiology part is really important. Now remember I said that chemicals and electricity are how our nervous system communicates with itself, right? So your body is going to release stress hormones and immune molecules and inflammatory mediators. Oftentimes we get an inflammatory response even without acute tissue damage. And this can happen over and over. We heard some evidence of that with repeated trauma exposure. Karen brought that up earlier. And I teach patients that living in pain is one of the biggest stressors that we know about. Living in pain every day, can't get away from it. It's very stressful. And it has chemical consequences. And pain is just one of the outputs. Now, in this context, when you can see on a list, pain is only one thing, that opens up some possibilities for teaching. Muscle tension is another, and this resonates a lot. People can either have muscle guarding, like whiplash and that tightness that you feel, or spasms. People with episodic back pain understand this. The spasms that kind of lock you down in your body, you bend over and you can't stand up. Muscle spasms, right? And I say muscle weakness is part of that too. Weakness is a form of protection. If anybody's ever slammed their hand in a car door or missed a nail and hit your thumb, you might remember that for a period of time, maybe a short period, but it was hard to wiggle those fingers. That's weakness and it's protective. And that can be sustained in long-term situations too. I saw a woman yesterday who was in the audience and she was describing to me at a break that she had developed left-sided lower extremity weakness only when she stood on that side. She could walk 4 miles, she could stand on the other side, but she couldn't go upstairs, and she couldn't stand only on this side. And she said, what's that weakness? Now, she had a history of a disc herniation that had resolved, but now, a few years later, the pain came back and this weakness. And so we did a little experiment, a little prove yourself wrong out in the stairwell, and sure enough, we got that leg to move differently just by changing how we talk about it. And I won't go into detail, you can ask me later if you want to know. But so then I say, look, these are all chemicals. And we know from pain science, the more recent studies are showing us that the longer stress hormones are released, the more the immune system gets overly active in releasing immune molecules, which are the types of chemicals that activate those nerves out in the body. So here we are, feeding the cycle. And this whole thing keeps itself going. And good news is, before you came here, you thought we had to do something to your body. Well, now we might not get very far if we do something to your body, because how many people have you seen who've tried to do something to your body, people like me, physical therapists, who actually made the pain worse? Yeah, I get that a lot, okay. Well, great news is, now we have all these things we can work on to change the way the brain considers this, and we can actually reduce that cycle over time. And I'm very careful to say this doesn't happen overnight. This takes a lot of work by you. You've got to be patient and persistent, but it can change. So this is a handout we'll make available, not probably till Monday, I think. But this is one that a colleague of mine developed and then I kind of formatted. It's a little bifold pamphlet that we have in the office, and we talk about the nervous system. So this is what I mentioned when Vanessa, I think, said, what do you say to substance users? Sometimes I'll pull this out. And this is the front part, and that's the back part. In the middle, we've got this. I'll go back to the front page, and just for those who don't see, you can change your nervous system's level of sensitivity up there, it says up top. And what contributes to a sensitive nervous system? And I've got a little dial that indicates what dials the pain up. Things like smoking, we know there's solid evidence on smokers, and reduction in pain just by stopping smoking. Alcohol, sugar, caffeine, all those things that contribute to inflammatory processes, right? Stress, inactivity, depression and anxiety, which usually develops after you've been in pain for a while. PTSD, and the population I work with generally understands that that's a contributor. They recognize the link between PTSD and pain. Medications, we talk about how medications, if they're not used as prescribed, can actually create more work for your nervous system and stress it out. And poor sleep, poor diet, and almost everybody who's had pain for more than a year, their sleep now is really disrupted. And that contributes to this sensitization. And so I say, but here, look at this list down below. These are all the things you can start to do differently to change that over time. And there's a long list here. You can get into a regular exercise routine a little bit at a time and build up. You can start to think about how to be more active or active in a different way. Build body awareness. That's really important. And the way I talk about body awareness is your alarm system has been trying to get your attention for a while now, and humans are really good at ignoring pain. That's part of the problem. And so if you're not good at hearing the alarms, which may not always be pain, your body might use other strategies. If you're not good at hearing the alarms, you can't heed them. And let me tell you, if your nervous system tries to get your attention and you ignore it, it'll find another way. Those might be the people that suddenly their legs drop out from under them, even though they don't have any frank proximal compromise of a nerve root, right? This happens, though, when they get scared. All right, so I'm going to read this because it's very small print. My colleague who initially developed the content here she worked at the time in Wisconsin, so this is a Green Bay Packers event. This is a linebacker sitting on a pink bicycle, belongs to probably a 10-year-old girl, right? So they do this fundraising event, and they go around and ride these bikes. And at the top this says, pain is our protection. Did you know that we have an alarm system? This child's bike will break if there's too much load put on it. And unfortunately, there's no alarm to tell this football player when that's about to happen. And our body has a threshold for damage too. But unlike the child's bike, we have an alarm system that lets us know when the damage has occurred. And it's so sophisticated that it can also let us know when we're about to be damaged or when we're in a situation that's similar to one where we were damaged in the past. And down here, this is from Lowe's work, Adrian Lowe or Adrian Lau, depends on, I'm not sure exactly how he pronounces his name. But this is from some of the booklets and things that he's developed. And the language here is the more often our alarm system is activated, the more sensitive it becomes. This is a normal adaptation of the nervous system, okay? It's much of what we feel with chronic pain is due to this sensitized alarm system and not so much to do with the original injury. So what this picture is depicting is we've got this general resting level of excitement that all our nerves have. We're buzzing with electricity, that's how we know we're alive. And generally, when that's well calibrated and not too sensitized, we have lots of room before we reach the top of that threshold, the dotted line, where the alarm goes off, okay? So we have lots of room to do stuff before our body tries to tell us to stop. But after pain persists, that threshold goes up, or the sensitivity goes down. So how much it takes to activate the alarm system is much less, which means there's very little room now for activities. And if you ask patients, have you noticed over the time you've been living with pain that every year it gets harder and harder to do something because it takes less to cause more pain? And they will say, yes, that's what that is. Tell them. I'm going to skip all this stuff because you can read it if you download it, and we've got more things to get to. So metaphors, I said I would bring some of this in. These are the 1.5 to 2 minute ways you can start planting new seeds. And as primary care providers, I know you don't get much time. I know that. And it's really hard. You have to cover so many health issues in one session. But if you can plant a seed or create some handouts that you can hand to people and say, we're going to talk about this when I see you again, that's a way to start. So thinking of pain as an alarm, this might seem simple to us, but it's amazing how people don't consider this as a way to think about their bodies. And alarms are generally designed to be helpful, right? And that's how a nervous system is supposed to work. And we hope that if you get a body injury that you feel pain so you can get help, right? But sometimes that's not important, or something else is a priority, like you need to get out of this canyon alive, and if you deal with the pain in your arm, you probably won't. So fire alarms are helpful when they warn us about fire, yes, but if your fire alarm at home went off, you'd probably call the fire department, and you'd be grateful that that alarm was there to wake you up in the middle of the night. Now, what would you do if there was no fire, just a faulty alarm, and then it kept ringing? And what if the fire department kept showing up to your house? You would start to think that maybe you're missing the fire, maybe it's in a basement, I don't know. And then what if the alarm went off whenever you lit a candle and your house wasn't burning down? That would be very disruptive. Hypersensitive alarms don't let us live very high quality lives. And I'm sorry for the footer got formatted a little funny here, so it's interrupting the verbiage. A hypersensitive alarm would interrupt birthday parties or romantic dinners, or might go off without any smoke at all. So this metaphor comes from retrain.org, which I think is on the little trifold. It's a great place to point patients to or have it playing in your office. It's a slide deck that they can just go through at their leisure. And it teaches a lot about pain science concepts with very simple images and phrases. So this one comes from Mike Stewart. He's another good pain educator out of the UK. People can understand how computers work or are supposed to work. They don't have to know the details, but they know the general expectations. We normally expect that there's some stimulus we put here out on the keyboard, and we expect the response to show up on the screen, right? And what we expect all the time is that you push 1x and you get 1x. But what's going on if you push 1x and you get 15? That's not right. Okay, well then I'd ask the patient, would you expect that a computer technician who comes over to fix your computer could open up the side of the computer tower and look at the motherboard and assess the problem and fix it? You can't, and nor can we take a picture of the inside and expect that that will help us understand the whole problem. It's not how things work. Sorry, this formatting is again getting in the way. So metaphor 3, orchestra, playing the same tune. So this is about sensitization and neurotags and how getting into ruts neurologically can actually impact lots of elements of your life, psychologically and socially. So an orchestra, this comes from the Explain Pain book. Thinking about orchestras in general, there are lots of different members, and this orchestra as a group can play a number of different tunes. All right, and that's when they're functioning well. But if they get into the habit of playing only one tune, several things will happen. They'll get really good at playing that one tune, really good at it. But they might lose a few orchestra members who get fatigued or they get injured because they can't keep doing the same things over and over. And they might start losing concert venues because the audiences get tired of hearing the same tune over and over. Our nerves get very good at playing this pain tune. Living in pain affects the sympathetic, the parasympathetic, the immune, and the motor systems. And it affects our social lives too. Our friends and family don't want to hear about our pain all the time. A lot of our patients stop talking about it. Now, what about this multimodal treatment? We've talked a lot about that today, and it's really difficult in this environment of care where opioids are now, we have enough longitudinal data to recognize how this is not a safe approach for most people, but it's hard to make that transition and get buy-in from patients, right? So I ask patients, and especially if I've had a conversation and I know somebody enjoys food, I say, have you ever baked a cake? Some people say yes. And even if they say no, have you ever watched someone bake a cake? Do you know what goes into baking a cake? Okay, we're on the same page. Can you bake a cake that comes out like this with only flour? Probably not. Now, it doesn't have cakes that are made up of lots of different ingredients, but flour can't be the only thing. You'll never get a cake out of that. Staying active and re-engaging in movement is not easy. A lot of people I see have been so conditioned to not moving because when they do, they get punished for it. And you probably have the same patients that I do in that respect. And so it's really hard to kind of get to the first step and recognize that movement is important. So using a metaphor like this, boats are nice and safe in the harbor. Your body might feel safe at home, but that's not what boats were built for. They rust up. They get leaks and holes and corrosion. That's not what they're designed to do, and that's not what our bodies were designed to do. So we've got a couple other things here that I'm not going to go through, but just so you know, they are on the website for your reference. They will be. And one of these, Adrienne Lau's booklets, one idea, we've got one of these in actual form here for you to thumb through. What we've done in our clinic is collected a bunch of different resources that the psychologist recommended that I've come up with, and we've created a patient library. So a lot of people I see don't have internet access and never will have it. And so we've developed a library system where we actually loan a book and provide a self-addressed stamped envelope for them to mail it back to us in case I don't see them for another 3 months and I want to give the book to someone else. So that's one thing, and then there are free workbooks that if you want to get deeper into a session of therapy with somebody, like movement therapy or pain science or whatever you want to do, doesn't have to be from a physical therapist standpoint. This was a booklet developed and it's free online by a chiropractor who went to PT school and now lectures a lot about biomechanics and pain science and reconciling those. So it's a nice resource, and just reading through that yourself, forget giving it to a patient, just reading through that might give you some more ideas about how to talk about pain differently. So a couple more websites, and then in the interest of time, I'm going to turn it over to Karen. Here, you need this.
I need this. So, I'm really, really interested in how we take care of ourselves.
And really, it was a selfish endeavor for me to think about this because I had a busy practice. I was seeing patients. I was the clinic manager. I was in doctoral studies. I got a family, got a 93-year-old mom, all of these things. And so I had to figure out some ways to make things livable for me so that I could continue to maintain the work. So I'm just going to, I don't need you to show of hands. I'm just going to throw this out there. How many of you are thinking you don't know how much longer you can do this? How many of you are concerned about taking a vacation because when you come back, you know your inbox with that electronic health record is going to be filled with all of that stuff, and it's going to take you 2 days at least to get through all that, and your patient, you're going to be full of patients that day. This is tough stuff. And so some of this, we just built in, you just have to take time to do it. So if it means, you know, when we would have our staff meetings, we would do, the bell would ring on the inside timer and we would take 2 minutes and just center ourselves and take a deep breath, right? We would stretch before we walk into a room. Sometimes it's just 5 minutes, man, 5 minutes. And you think, where am I going to give 5 minutes? You just have to take it. I kid you not, some of those stretches just have to sometimes happen when you go to the restroom. You just have to find the time to do that. Feeling the ground and the earth underneath you, looking out your window, taking those slow, deep breaths to just put the brakes on your body in order for us to do the work. We do so much for our patients, so much for our family and community. There's not much time for us. And then we see folks who just can't do it, and they leave the work. I'm going to skip past this just because these are all on there. There's stretches for relief at work. There's stretches for pain and things like that. And the couple things I want to throw in is some of the ways that we got this information to our patients is we put a big TV monitor in our waiting room. And we had I had volunteers. I couldn't have done the work without volunteers. So I said to them, I want this content, this content, this content, this content, and I want it to be a script and we roll it. So we had stuff on chronic disease, on diabetes. I had a patient who ended up getting his colonoscopy exam after I'd been talking to him about it a year because he saw the video and the video told him how important it was. I was like, okay, yeah, we can get that. We can get that now. I've been talking to you about that a long time, but we can do this. So you can have this stuff running in your waiting room. I want you to think about community and bringing community in because some of this education, the common thread in all of this conversation today of everything that your health plan has been doing is around education. Some of it has to be done by providers, but some of it can be done by others. So leading from where you are, but leading is also getting your work done through others. And I'll say to you, at Glide Health Services, a lot of our classes and our groups and our education were done by students. Nursing students, social work students, public health students that had to do what? They had to do a group assignment. We had an entire diabetic education course that was done through Literacy Tracker. It was about 3rd or 4th grade level. It was done in 2 languages, all student work supervised by a provider or somebody else in the organization to make sure the content was appropriate. And so patients could come and they could get this content, they could do all of this work. The student got an opportunity to do an experience in front of a group of people, all of that. So I don't want you to think, oh my God, I got to go and do this, more of this work. I want to get to this last one. This was so amazing to me when I decided that I was going to start doing this in my own life, is waking up every single day. Some of the recommendations are, this says 5 things to be thankful for. You know, this morning I just had 3 things to be thankful for. I mean, I just found 3. I didn't have a lot of time to find 3, but it's 5. But it's amazing how much better you feel about that. I actually had this experience the first day I drove down, and I was sitting in a restaurant, and I had been kvetching about something, you know, something about the job or this, or I was tired and all this other kind of stuff. And then it just dawned on me, it was like, you have such privilege. You've never spent a hungry day in your life. You've never spent an unhoused day. This is my experience. Never spent an unhoused day. I've got a family who loves the very ground I walk on. I got a mama and a daddy who, there's a lot to be thankful for. When I looked out, I was in the restaurant and I looked outside and I thought, look how beautiful that sky is. It's blue, and I actually have the privilege that I can appreciate that it's blue. I mean, it's those simple things, and it just really made me feel better. So I'm going to say to you, what are you thankful for today? What are you grateful in your life today? We know you got a busy panel. We know you got a lot of patients. We know you got a lot of stuff to do. But what, as you stand on the ground today, are you glad that are happening, that you're privileged, that maybe somebody else is? That's important to do that. It helps your well-being to think about that. It actually, listen to this, makes our immune system stronger. It lowers our blood pressure. All of these things, the simple thing of being grateful. To go home to your babies and your family and your dog and just say, you know, I'm glad you're in my life. You might be making me sick right now, but because I'm frustrated that you didn't wash the dishes or whatever, but I'm glad you're here. I'm glad you're here. Okay. So that's really what I want to say to you, is I want you to be in this work a long time. I want you to thrive in this work. And if you don't put yourself first sometimes, it's just not going to happen. You won't be able to continue the work. That's it.
Great. That was so important. It's hard to follow on that, but I am going to offer something I'm grateful for, which is a manual done by Diana Koffa and Susan Scheidt called Body and Soul. And Morgan and I have been using this in our clinic. It was designed for groups, on a group at the General, San Francisco General, on chronic pain. It's 12 sessions. Each one starts with 3 breaths and a movement exercise and something to think about. I'm going to pass it around. It'll be on the HIP website, and I encourage you to look at it and consider it for your chronic pain group if you're going to start one. Right, so we don't yet have a group in our health center, and Morgan's been passing this out, and I think it's been an extraordinary response by people. Yeah. So I have 2 other books that I got, one called 101 Trauma-Informed Interventions, and then a mindfulness book. I'm going to pass this around, and I'll say another thing I'm grateful for, and that's Dale Bishop at Central California Alliance for Health. We're so lucky to have you at the helm. Doing this work and being able to offer CME like this. Thank you, Dale. Really, really appreciate it. And Dale's going to walk us through now what the Alliance is doing. And we're going to have Sibel Lally from Beacon as well.
So I'm going to stay with the grateful theme. And first of all, thank Karen and Kate for coming today and sharing all of their insights with us. And I also want to express my gratitude for the HIP team that put all this together. Jen, Cedra, Pam, and Ryan were the leads on this. They found our great speakers and they put all this together, so please give them a hand. So I want to just kind of quickly go through some of the Alliance's perspectives, kind of the things that we've kind of developed for our, I'm going the wrong way there. Here we go. Pain management program, and starting with that we know that there's a problem with pain prescriptions regionally and certainly locally in Santa Cruz. This particular slide shows morphine equivalents per resident per year in the first column, ED visits per 100,000 per year, and 5-year death rates per 100,000 between 2009 and 2013. This is California Healthcare Foundation data. So you can see that all 3 of the counties the Alliance covers are a little bit above in terms of morphine equivalents per year. ED visits are pretty high in Monterey and Santa Cruz, and death rates, which is really concerning, are high in Santa Cruz. So with that, just real quick, summary of that CDC MMWR, which was mentioned earlier, came out in March, and basically for acute pain, they're recommending opiates as last resort, lowest effective dose. I thought the fourth line here, about 3 days or less, will often be sufficient for acute pain. More than 7 days rarely needed. And then chronic pain, avoiding continuation of the acute pain, and really getting into these numbers of greater than 50 milligrams of morphine equivalents per day being concerning, and 90 definitely being something to try to avoid. That's actually significantly lower than CMS and the medical board have been saying for a couple of years, which basically been using 100 and 120 kind of numbers. So they have a few other recommendations, certainly for safety, naloxone, using the CURES program, urine drug testing, and then using evidence-based therapy, medication-assisted therapy with Suboxone, et cetera. So those are available now and very helpful to go through with a little more time than we just did, but I think you'll find them helpful if you haven't already looked at them. So from here, I just wanted to mention what the Alliance has been doing to try to help facilitate better pain management. And the first thing I wanted to mention was that our pharmacy department's been doing quite a bit of work on communicating, monitoring, and trying to help providers with this. I'm going to actually introduce Michael Blatt, one of our pharmacists, who's actually been one of the leaders in this particular area.
Thanks, Dr. Bishop. So, you know, to help with all these initiatives, one of the things we started reviewing our treatment authorization requests. Any requests for a patient's opioid regimen that goes over 120 morphine equivalent dose, we're looking to make sure that there's chart notes or referrals to PT and use of other modalities. In any of the more complex cases, we're referring to the medical directors or Dr. Bishop. Additionally, we're working closer with our care management department. So patients, if we see them on opioid prescriptions from different doctors, various benzodiazepines, and just looking, you know, these patients that look like that, you know, they're not benefiting from this opioid treatment and they're going into the 500 MED, 600 MED range, we're referring it to our Alliance case management department where they have licensed clinical social workers, nurses, where they can, you know, kind of make sure that the patient's getting coordinated care. And thirdly, in this upcoming P&T, we're looking to help our clinicians with drug choices. We're trying to loosen up the formulary. For example, we're looking and possibly adding generic Voltaren gel and generic lidocaine patches to make it easier so you guys don't have to fail the TAR. So, and for now, until then, if you know you feel like you want to use those drugs, the lidocaine patches and Voltaren gel to curb opioid escalation, we're not requiring any of the other steps to get it. Just put it on the TAR that, you know, you're concerned about narcotics for this patient, and we're just approving it times 1 year. So that's what the pharmacy department's up to. For both, we're looking into both.
When does that start? Because I recently had rejections.
So P&T is coming June. So if you're getting rejections, you know, any suggestions, please take my business card, and we'd love to get any of your input for this upcoming P&T. Pain is definitely a therapeutic class we're going to look at, and we really want to make, you know, your jobs easier. Yes?
Why can't we just get it on the formulary, the lidocaine patch and the Voltaren?
It has to go through P&T, so we have a P&T committee that meets quarterly, and that's just part of the policy and procedures. I know, yep, I totally agree with you, but as long as you submit to TAR and put that you want to avoid narcotic escalations, we're pushing them through. Okay?
What if we want to avoid narcotics altogether? Right?
Put it on the TAR.
Okay, so you can say that rather than escalation.
Yep.
You can just say avoid altogether.
Yep, put it on the TAR, we're going to push it through. Okay?
Yeah, thanks.
Thanks, Michael. Yeah, unfortunately, we are a little bit of a bureaucracy. We try to make things as easy as possible. We still do have policy procedures we have to follow. I don't want to go through too much of this other than to kind of go down to the bottom and say that we do have mental health counselors through Beacon with the expertise in counseling members with chronic pain. I'm going to turn it over to Sibel Lawley, who will cover that for you.
Thanks, Dale. Just the middle one? I've never, so high tech. Okay, great. Perfect. So Hello, everyone. I was asked to throw a couple slides together, and I love that my very short slide matched the brilliance of the slides that we had before. So I feel like I'm kind of in the know, which is good. But I'm Sibel Lawley. I'm the program director for our partnership located team with the health plan. So my team here is co-located in the health plan's territory. And what we do is the behavioral health services for the mild to moderate benefit that rolled out. And I wanted to just kind of skip over this because we talked pretty much of that and get to how you get to the clinicians. But I think the main thing that I want, that's sticking with me today, and also what I want us to just pause is, it's really important to know who's in the room with you, right? There's ways that we can see someone, usually from our compassion fatigue and our time for the next patient, or they're not showing progress. But they're also what I call a chronic pain warrior or a chronic pain survivor. They're doing what they need to do and can do to stay living. It's, so back to the opioid, I think my other flash was it's a little bit like a seesaw. If you pull one off, slam to the ground, right? So you've got to gently communicate and find the balance to be able to help the individual access the other services that we're going to talk about. But just to pull one is terrifying for someone who lives in chronic pain. That can mean suicide, right? It's so terrifying to just pull out. So the more we can communicate, do it collaborative, all that, it will be brilliant. So on here, I love this training because on here, yes, resources for the PCPs. You guys are the primary spot for people, right? We heard stories of people who will only go if they're so far beyond what they can manage. They show up, but they're coming with, again, anxiety. They want you to believe them. And then if we meet them, maybe not with that belief, then they don't come back. And that's why they'll do other strategies to help them live. So connected here in our network, the website's on the bottom. You can go to there. You can search for providers, and you can search by specializations. We have chronic pain as a specialization, and there's a list of clinicians in different counties. You also can search for pain management. You can search for CBT, cognitive behavioral. You can search for, what was the other one I looked up? DBT. We didn't have mindfulness. I'm like, oh, I'm going to change that. We do have benefit for group therapy. We do individual and we do group therapy. The interesting piece on there is, so I hope we could do family therapy, because another element to this is these individuals live in isolation and silence. We heard that, right? No one wants to hear my story anymore. And so I'm living it alone. But the family needs help to understand as well. So how to bring that in, even in a group setting, would be helpful. Mindfulness, movement, but the whole element is connecting back to the website. Also on the CCH website, we have tons of information on how to do the Pcp referral forms. And our team also goes out and does education with the health plan staff to help all the PCPs figure out how to do the referrals to get behavioral services. So we're trying to make it very streamlined and easy for you to access our network. 5 minutes, meaning for him.
Yeah, you're done.
I'm done.
I think, unless there's questions for Sibel. Okay, I'm just going to wind things up here, I think. So through your efforts over between 2014 and 2015, this is the average dose of milligram equivalents per day of opiates, morphine equivalents, in 2014, which says prior, and 2015, which was current when the slide was made. And basically, this is for, so again, people who are over 120 in 2014 were on an average of 425 milligrams per day, and in 2015, that dropped down into the low 300s. So there has been a decrease in the overall doses, which from a safety standpoint and quality of life standpoint is really a good thing at a high level. So our hope is to continue the current dose reduction trend through some of these efforts, and clearly the next step is to promote the care of the medical, behavioral, substance use disorder needs, social determinants of health, clearly adverse childhood experiences and neuropathology of pain, neurophysiology of pain have to be considered too. So that's what I have. I think we got it done in 5 minutes. Any other questions or thoughts?
Would you share
what some of the major challenges were?
Well, I think our number one barrier in terms of just having, even things like Voltaren gel, which we kind of mentioned earlier, we actually are, without a board approval, we are really supposed to use the Medi-Cal benefit package. So the Medi-Cal benefit package, for instance, doesn't have acupuncture, chiropractic. We did add those, but it was a process of over a year to demonstrate to our board that that was helpful and it was important, and the board approved it, and now we have those things. So, again, even the Voltaren, those aren't Medi-Cal benefits, so to add things, we have to go through a process. So I think, in general, I think through provider support and our board, they've been very helpful to try to get these things moving forward, but we have to really design them, think of them, and then prove that they're helpful, and then move forward with them. So it's just sort of a slower process than we might like sometimes. Great ideas come up, and we'd like to put them in place immediately, and some of them, unfortunately, can be put in place, but some of these other ones have to take a little bit more time.
Great, thanks. Thank you, everybody. Unless anybody have other questions, I know that